right, let's talk about something you're going to see all the time in the clinic, a patient complaining of leg pain when they walk. It's a classic clinical puzzle, and getting it right is absolutely crucial. Today, we're going to break down the two big players, true vascular claudication and its tricky mimic, pseudoclaudication. So the best way to tackle this is to frame it exactly how you'll see it. So let's start with a patient case. Okay, picture this. A 70-year-old walks into your office and says, "Doc, my calves just ache every time I try to walk for more than a few minutes." This is a textbook presentation. Right away, what are the first two things that should be popping into your head? This is the exact puzzle we're here to solve. Let's line up our two main suspects for this kind of leg pain. You know, on the surface, they can look really similar, but where they come from, totally different worlds. So on one side, you've got true claudication. That's a vascular issue, pure and simple. It's caused by arterial insufficiency. And on the other side, you have pseudoclaudication, which is actually a neurologic problem that comes from lumbar spinal stenosis. I like to think of it this way. One's a plumbing problem, and the other is an electrical problem. The reason for that plumbing problem, that true vascular claudication, is peripheral artery disease, or PAD for short. At its core, it's really just a supply and demand problem. You've got atherosclerosis that's narrowing the arteries in the legs. So when the muscles start working and demand more blood, the pipes are just too clogged up to deliver it. And whenever you're thinking about PAD, your brain should immediately start running through this checklist of risk factors. Smoking is a huge one. Then you've got diabetes, high blood pressure, high cholesterol, and of course, just getting older. Our 70-year-old patient, well, they already checked that last box. Now, here's what's really cool about all this. Your most powerful diagnostic tool isn't some expensive fancy scan. Nope, it's the conversation you have with your patient. The history is everything here. The whole game is about asking the right questions. The little details of the pain, like when exactly does it start? Where is it? What does it feel like? And maybe most importantly, what makes it go away? The answers to these questions will almost always lead you straight to the diagnosis. Okay, this table really breaks it all down. For vascular claudication, the pain is super predictable. It feels like a muscle cramp, and it stops pretty quickly if the patient just stands still. The muscle just needs a quick break to catch up on its oxygen. But with pseudoclaudication, the pain is way more inconsistent, and it feels more like numbness or tingling. And here's the key differentiator for relief. The patient has to change their posture. They have to sit down or lean forward, like on a shopping cart. That's the famous shopping cart sign. You got to remember that one. All right, so you've taken an amazing history. Now, your physical exam is where you're going to find that hard evidence to really back up your suspicion of PAD. Your physical exam really just builds on what the history told you. A really good vascular assessment means you're checking all the major pulses in the legs, you're listening with your stethoscope for that whooshing sound of a bruit, and you're taking a close look at the feet for other signs, like shiny skin, hair loss, or any wounds that just aren't healing. These are the classic findings you're looking for. I mean, if you can't feel a pulse where you expect to, or if it feels a lot weaker than the other side, that's a huge red flag for a blockage somewhere upstream. Same thing goes for hearing a bruit. That sound literally tells you there's significant narrowing right under your stethoscope. So your history and your exam are both pointing strongly toward PAD. Now what? How do you actually confirm it? Well, you can do it with a really simple, non-invasive test. We use something called the ankle brachial index, or ABI. And all this test does is compare the blood pressure down at the ankle to the blood pressure up in the arm. It's just a straightforward ratio, but it gives us an incredibly powerful diagnostic answer. And the process itself couldn't be simpler. You just measure the systolic pressure in both arms, and then in two different arteries in each ankle. Then, for each leg, you take the higher ankle pressure you found and divide it by the higher of the two arm pressures. That's it. That's your ABI. And this is the number you need to burn into your memory. An ABI of 0.90 or less is diagnostic for peripheral artery disease. It means the pressure down in the leg is way lower than in the arm, which confirms there's a blockage somewhere in between. Just for comparison, this is what's normal. Usually, the pressure in the ankle should be about the same or maybe even a little bit higher than in the arm. So a normal ABI is going to fall somewhere in this 1.0 to 1.4 range. But wait, there's a really important catch. If you get an ABI above 1.4, it doesn't mean the vessels are super healthy. In fact, it kind of means the opposite. It suggests they're so calcified and stiff that you can't even compress them properly with the blood pressure cuff. You see this a lot in patients with long-standing diabetes. So, you've made the diagnosis, you've figured it out. But it is so important to understand that PAD isn't just about sore legs. It's a flashing warning sign for a much, much bigger problem. This quote says, everything you need to know. Atherosclerosis is a systemic disease. If those pipes are clogged in the legs, you can bet they're also getting clogged in the heart and in the brain. Making a diagnosis of PAD automatically launches that patient into the highest risk category for heart attacks and strokes. What does that mean in real terms? It means their risk of having a heart attack, having a stroke, or even dying from a cardiovascular cause just went through the roof. That leg pain is basically a warning siren for their entire vascular system. And this is why diagnosing PAD is not the end of the story, it's actually the beginning. It's a golden opportunity for you to step in, get aggressive about their risk factors, and potentially save their life. And that really brings us to our final and most important question. The leg pain is what brought them to see you, but your job now is so much bigger than that. You need to be thinking about things like high-intensity statins, getting their blood pressure under tight control, and getting them to stop smoking. So how are you going to take this diagnosis and actually change this patient's future?